speaker comes to us from Eastern Canada, all the way from the province of Quebec. His name is Dr. Alain Belanger, and he was a full professor at the Department of Rehabilitation in the Faculty of Medicine at Laval University. So he too has worn many hats throughout his career, and he currently is a consultant for physiometrics. Along the way, he's obtained his Master's of Kinesiology at Simon Fraser University and his PhD at McMaster University. And most importantly, again, he's currently retired, but most importantly, he is the author of this beautiful textbook. So again, you can never have too many modalities textbooks. So I encourage you to pick this one up as well. It's called Therapeutic Electrophysical Agents. Please, let's welcome Dr. Alain Belanger.
Share screen. Good afternoon, bon après-midi. All of you are here today to find out what's new, what's exciting about therapeutic modalities, right? And you are also here to optimize your practice through evidence. Okay, now I have a warning for you. The presentation I'm about to give is shocking. Okay, so your attention is advised. Before I begin, I want you to experience what a shockwave is. And before I show you this video, I want you to keep in mind that the speed of sound is roughly 340 meters per second. Keep that in mind because after the video, I have a question for you. So, watch this video. It's coming. All right. Now my question for you. Whoops. Maybe I'll go back up. A question for you. Can you tell me at which distance the camera was from the site of explosion?
1 mile.
1 mile. How do you know that?
Pretty round number is around about a quarter of a second.
Wonderful. If you pay attention, you notice, many of you, that it took about 6 seconds from the time we saw the beginning of the explosion about the time we heard the sonic boom. So yeah, if you multiplied 6 seconds by 340 meters, you end up roughly at 2,000 meters. Now, all of you that have a good answer here will remain seated for the rest of my presentation. Now, those that did not get the answer, well, Dr. Valdez told me, I'm sorry, they will have a second chance, but if they fail, then they're in trouble. So here's your second chance. Now, you may think that this is a quiet day at the beach. Is it? Same thing. If you noticed, by the time the jet broke the speed of sound, because it did, you saw the cone at the back. And by the time you heard the, so I'm going to get out of here. But by the time you heard the sonic boom, it took about 3 seconds. So if you were to multiply 3 by 340, you get about 1,000 meters. So the people at the beach were about that distance. Well, shockwave is all about the speed of sound. And the speed of sound in air is roughly at 340. It is 4 times faster in water. And here you have a visual display of this plane breaking the speed of sound, shown here as a vapor cone behind the plane. Okay. Over the next 40 minutes or so, I'm going to be presenting you a relatively new mechanical agent in the field of electrophysical agents. And I will show you these things. I will show you that, yeah, it is a new one. It is roughly 15 years old. Okay? The evidence show, because it's based on evidence, that it can induce or generate promising therapeutic results. And contrary to other types of therapies, shockwave therapy is non-invasive, and this is crucial for us in the field of rehab. This is the alternative we bring to the table. It is relatively low cost. Now, I'm not talking of $200 here. You will not find a shock device for $200, not even for $2,000. We're talking roughly $10,000, $15,000 for that. But this is cheap in comparison to what is there right now, and you will see more of that at the end of my presentation. And I will show you that this form of therapy is perhaps the best alternative we have to surgery for the management of something that all of you are dealing with in your practice, that is the management of chronic tendinopathies. And I will illustrate a case later. I will put it clinically for you by using a case of chronic tennis elbow. All right. Now, to do that, I will be presenting on those different topics. I will be speaking about the biophysics. This will be an overview. Talk about the physiological therapeutics effect, talk about the symmetry, the application, talk about the research-based evidence, because we know in our field, it seems like every year or two, there's a new device, a new type of things, and it's pushed by several companies. Marketing is fantastic. Ask yourself all the time, where is the evidence? If you do that, you're on a good path to practice with a lot of solid foundation. And I will end my presentation with this case of chronic tendinopathies using lateral epicondylitis. What's a shockwave? A shockwave can be simply defined as a very, very brief, very, very high amplitude acoustic or pressure wave. Now, when I talk acoustic pressure wave, some of you says, well, no big deal. It must be another type of ultrasound. Is it? What's the difference between the ultrasound that all of you know and the application of shockwave therapy? Let's have a look. Here I contrasted for you, based on 4 parameters, the difference between a shockwave and an ultrasound wave. Quickly, if you look at them, you can see the difference. I'll speak briefly to that. Peak pressure, we're talking of an acoustic, we're talking of a wave that will create pressure in the tissue. And our basic ultrasound does that, but compare the pressure. Look at the ratio. It's almost 2,000 times stronger, a shock wave. Look at the waveform. A shock wave, and you will see a picture of that, is a biphasic asymmetrical wave. Our ultrasound, of course, it's biphasic symmetrical. It's sinusoidal type of form. Frequency. Shockwave therapy is delivered at a very, very low frequency, rarely exceeding 100 hertz. In comparison to our 2 well-known ultrasound devices that will generate ultrasound waves at either 1 meg or 3 meg. And finally, the effect. Shockwave is pure, 100% mechanical effect in the tissue. Ultrasound. Well, I read the literature, and for me, you may disagree with me, but 99% of the effect of ultrasound is thermal. This little mechanical effect that we attribute to ultrasound, I have yet to read a solid paper on it. So for me, when I use an ultrasound, it is above all for its fantastic thermal effect. Okay, When you deal shockwave, you will face this in the literature. You will have the choice between a focused shockwave or a radial shockwave. Well, the term says it. And by the way, ESWT stands for extracorporeal shockwave therapy. The F stands for focus, R for radial. You will see the difference between the two. And at the end of this presentation, I will answer a question. Which one is best? Should you buy, or should you use more of a radial shockwave device or a focused one? I will answer this question. For the time being, briefly, here is what you have. To generate a shockwave, the industry used 3 different mechanical principles, I would say, or generators. And these are the electrohydraulic, electromagnetic, and piezoelectric generators for focused shockwave versus the ballistic for the radial. For the sake of time, I will not describe these 3 here for focus. Just keep in mind that electrohydraulic, well, we spark 2 electrodes in water. They generate shockwave, they are reflected and focused. The term focused, the beam is focused, converge towards the target tissue. Electromagnetic, this time we use a very high electromagnetic current that will vibrate a membrane, all this in water, and this will be reflected back and will create a focused shockwave. And piezoelectric, well, these you have here hundreds, thousands of those piezoelectric transducers that we know about because they are the basis of our ultrasound, right? But here they will vibrate at a given frequency and will generate shockwave that will be again focused. The radial, let me tell you more about it. It's based on the ballistic. Yeah, there's another mechanism, but I will not speak to it today. Ballistic generator, what do we have here? Here we have an end piece. This is your piece that you will be treating with. It looks like a gun, but keep in mind that the structure is this. You have a projectile there in red that will be moving in a cylinder and will come at the end and make an impact on a steel surface. And this will then create the shock wave. In other words, what I'm saying here is that through compressed air, this compressed air will accelerate this bullet in the cylinder. It will be accelerated at a very high speed, will hit this, and then the radial shock wave will be emitted. Here we're talking of a transfer of kinetic energy. You know what kinetic energy? It's half time the mass of this projectile multiplied by the speed, the square speed to which it is flowing. And this kinetic energy will be transformed into a impact energy when it hits the surface, the steel surface. And then when that happens, this impact energy will become a short wave. And this short wave will penetrate the tissue for the purpose of treating. Now here's the contrast of a focused versus a radial shock wave. Okay? And there's 4 parameters there. Keep in mind those. P plus, that's the pressure, the amplitude of the wave. P minus is the tensile force. We're not dealing with this because it's very small. The focus is on the pressure wave that will create what we want to create. The second parameter is the pulse duration, the rise time, and there you go. Now, if you quickly look, you can see the difference is that a focused shock wave generates much more energy, much more powerful shock wave as opposed to the other, and the wave is much briefer. And here I have a mistake. Correct milliseconds. That's in the book, and it should not be there. So we're dealing of microseconds. I'm sorry. Remove milliseconds and put microseconds. Let's say later you watch this presentation. So this is what you have basically to differentiate them. Now a brief word about the history of shockwave. It started in Germany. It started in the late 1970s. And in 1985, the first patient in urology was treated using a lithotripter for lithotripsy. What is lithotripsy? It is the crushing of a kidney stone. The surgeon used to do it surgically. Now with Shockwave, you don't have to. And here's the device. And I will quickly talk to it. Here you see FESWL. The L stands for lithotripsy type of wave. This is the most powerful shockwave on the market to use with humans. We in the rehab field use less powerful shockwave. And it is a focused shockwave. And what does it do? It is used to destroy something. So the effect is destructive. And to destruct the kidney stone, the principle is cavitation, unstable cavitation. Those bubbles will eventually explode. And when they explode at the surface of the kidney stone, they release tremendous amount of energy. I mean, in a gigapascals, but it lasts for only a fraction of a nanosecond. And those millions of bubbles crush the stone, and bingo, you get rid of it. So, but in order to do that, the surgeon will have to make sure that he's shooting this shockwave at the right place. So the patient lies here. On top, you have an image guiding system. Could be fluoroscopy, could be ultrasound. Then the surgeon uses that to focus on where the kidney stone is. Underneath, you see the shockwave device. Then when everything is aligned, bingo, we go. And this, of course, hurts. So the patient is under local anesthesia. Now, a few years later, the German says, hey, that works well. Why not using this to treat soft tissue like tendons, perhaps wounds, perhaps bone? And they did some research. And they came up with a new term called orthotripsy, the application of this in the field of musculoskeletal problems. They have provided us now with two types of wave, focused and radial, as you can see here. And here we have biological effect. We're after treating something. And I will come back to this. So therefore, there's no question we're not going to use unstable cavitation. We know that our basic ultrasound doesn't do that because its intensity is way too low in order to do that. So here we're going to have shock wave with fair amount of energy, but will be kept under the unstable cavitation effect. For the focus, because it's focused, you're going to need an image guiding system. The image guiding system, I will show you a device soon, it's ultrasound guided system. And analgesia, well, it's optimal, it's optional. It depends on your patient. Yes, it hurts a bit, but you can stand this. I mean, you don't have to receive analgesia before. As far as radial, well, it is the patient that will guide you. So you don't need an image guiding system. You will palpate, the patient will tell you where it hurts, and then you will dig it out and find out where the lesion is and how deep it is. And I'll come back to the concept of how deep it is because it's crucial to clinical decision-making later. Now, no analgesia is required. Everybody can stand this. It's not really comfortable as a treatment, but all of us can stand it. Here you have a picture of orthotripters, 3 of them. They were made by Stores. Stores, yeah, it's a German company. And here you go. Here to the left, you have a radial shockwave therapy unit, roughly $10,000. Depends. Then here in the middle, you have the radial shockwave therapy, and on top, you have the ultrasound guiding system. And totally to the right, you have the radial underneath, you have the focused shockwave on top, and on top of all of that, you have the image guiding system. So you can see that the billing, the cost of this technology can add up because ultrasound guiding imaging system are not given. Okay, let's go back to this fundamental parameter. It is, after all, the amplitude of the shock wave that does the work, okay, because they are similar in terms of timeline. Here I contrasted lithotripsy, and look at the pressure of that wave, up to 1,200 bar or 120 megapascal. This is this really shocks you, believe me. And if you were to measure it in terms of energy as opposed to pressure, the unit in this field is millijoule per millimeter square, and it's up to 3. This is the range of a lithotripter. We use orthotripters, so we use focused and radial, and our pressure are lower, as you can see here. Okay, Now, there is something in the industry. When the wave is not focused, we appreciate the amplitude of the wave using only one unit, that is pressure and measure in bar. But if it's focused, you may have the option of recording your amplitude either by pressure in bar or millipascal, or in energy in terms of millijoules per millimeter square. Now, our friend at the bottom, ultrasound. Ultrasound, of course, is a sinusoidal wave, 1 meg, 3 meg, and very, very low pressure compared, 0.5 bar only. So it's not used, it's not a shock wave. And here the unit is measured in watt per centimeter square, its energy, as opposed to the energy measured for shock waves. All right. Now let's have a look quickly at the physiological and therapeutic effects of this. This is for both. Focused or radial, there's no difference. And the evidence, what I'm going to talk about, is strongly supported scientifically. There is a long list of papers published in peer-reviewed journals done in vitro, in vivo, in animals, and more recently on humans that supports what I'm going to tell you. It's not guruism, it's not something I pull out of my hat in the evening preparing a presentation, because this is something, you've been in the field, you know what I'm talking about. There's a lot of those magic therapy out there. What does it do if you were to expose a condition like a tennis elbow? Well, you will micro-traumatize. You will actually cause an injury. You use something to treat, but to treat, you're going to have to cause the injury, and I'll tell you why you have to do that. In doing that, you will induce neovascularization. How do we know that? Well, scientists, you know, they use all kinds of stuff. And they show that following the application of shockwave, you will have the release of growth factor, vascular growth factor, platelet-derived growth factor, all this needed to make the tissue heal. You will improve blood supply. You will have this nice proliferation and differentiation in cells. You will end up with an increased collagen synthesis. And at the end of the day, you've been using this to try to treat something that was stalled. The process is stalled, and you will see more about that in my clinical case presentation at the end. Now, this slide is crucial. This, you've been taught about that, and you will never, as long as you're a clinician and work with musculoskeletal injuries, you should never forget what is there. It is the 4 phases of soft tissue healing. It applies to bone, it applies to skin, it applies to everything you want. It all starts often with an injury in our field. And then you, of course, you have hemostasis, and then you move on in the chain, and you end up with, when remodeling and maturation is done, you end up with healing. What's the problem with the chronic tendinopathy? Why is it that people will drag this for months? We'll see several clinicians. We will use different agents, but it's still there. What's going on? The problem is here. It is in the inflammatory and proliferative phase that this agent has its place. I like when and you've seen it perhaps in my book, that I like to know when it's time to use an agent. I think that's something that we must do. It's okay to pick one up, but we should not be using the one that we have in our clinic to treat. We should be using the one that is needed. And how to know if it's needed? By trying to clinically establish where your patient is in this framework. Okay, I'll come back to this. Now, you will ask, you remember, you're here also to optimize your practice through evidence. Am I talking over my head here? Am I telling you that it's good because I have shares of the company? No. No, that I can assure you. Nobody will buy my scientific way of looking at this. Nobody. And you too, I'm sure. So what I did, like everybody, I started to read on the topic. I attended the first one, actually it was, I think, the first international congress on shockwave, and when somebody has to go to bad places, I ended up in Rio de Janeiro in Brazil And so it's terrible, but it's okay. I recommend you go there. And you will see at the Olympic how these beaches are beautiful. So to make a long story short, I was able, only in my book, to pick up over 115 studies, not to show that it treats well the rats or the pig or the horses. These are all human-based peer review articles. And the picture is this. Feel confident that this is something you can use, scientifically speaking, for these 4 conditions. Shoulder tendinopathies, whether the tendon is calcified or not. You can use it for elbow tendinopathy. You can use it for Achilles tendon, patellar tendon, and plantar fasciopathy. Podiatrists are using this, physical therapists, physiatrists. I'm sure athletic trainers are using it too. The chiropractors are into it. I mean, everybody is there and can have a crack at it. The symmetry now. It's one thing, like our distinguished speaker mentioned, that, hey, the trilogy is telling you about frequency, duration, and amplitude in this field. Let me tell you that this is what you have to memorize here. Because when you decide to make a treatment, you're going to have to determine the energy per shock or the pressure per shock, depending if you use a focal or a radial. I'll give you an example of dosimetry in a few seconds. The number of shocks, the shock frequency, the number of treatments. When you establish this, you'll be able to calculate 3 things: the dose per treatment, the treatment time, and the total energy dose given to the patient at the end of your treatment. Here's an example. Application of focus, Shockwave. I just made it up, this prescription. Let me talk to it. Energy per shock, I decided that it was going to be 0.18. Well, remember, the range is between 0 and 0.6. This is scientifically established. Above 0.6, you enter the zone of destruction. Okay? Number of shocks. I said 2,000 here. Usually, treatments are given between 1,000 and 3,000. Shock frequency. I said 10 here. The range is between 1 and 100. Treatment frequency. Usually, you treat once a week. Once a week. And how many treatments? Usually, 1 may be enough, but maximum 4 is usually what you see in the literature. If after 4 treatments, you don't have the results, and by the way, don't expect immediate results. It will take time. It may take as long as 12 weeks before your patient becomes symptom-free, because it takes time for those neovascularization and this releasing a growth factor and all this to trigger another injury that will build up in healing the situation. Now, here are the calculations. There's a few formulas, and you end up with dosage. In this case, 360 millijoules per millimeter square. Your treatment time, if you know how many shocks you're going to give, and you know the frequency at which you give them, this is basic arithmetics, and you end up with 200 seconds or 3 minutes and 20 seconds. And then the total energy, well, it's the energy during 1 treatment multiplied by the number of treatments, and you end up with that value. Here's a radial, same thing. The only thing that changed here is that I'm not expressing the energy in millijoules per millimeter square. I'm expressing it in bar. And the rest is my prescription. And there I can calculate this. Well, some of you will say, well, you know what? Formulas and calculation, it's not my cup of tea. You know, I prefer to be focusing on what I do clinically. Fully understand that. What did I do in the last edition of my book? I build up online. If you log in, you will have access to dosimetric online calculators. You just enter a few parameters of those, and you click, and you will have the numbers I just gave you. So you don't have to memorize that. You don't have to do hand calculation now. It's there. And I invite you to use it, because it will make you appreciate what you're doing. It will give you some foundation to what you do, and you won't have to spend time with calculators doing all that. What I want you to know is what the formula means. That, of course, you need. But as far as doing the routine thing, this can do it for you. The application now, let me give you a few words about the application. When you consider applying Shockwave, you consider those parameters. lesion size and depth. This is important because this is on this basis that you will determine if you should be using a focused shockwave or a radial. Give me an example. Focus means that the beam is focused. So the smaller your lesion and the deeper it is, go get a focused, use a focused shockwave. If it's larger, more superficial, radial shockwave will do. Location of the lesion, where is it? Of course, if you use focal, you will have image guidance. And if you use the radial, the patient will guide you. As far as the coupling agent, you will need a aquasonic gel, like the ultrasound. This is a mechanical energy being transferred to the tissue. And you'll need a coupling agent. And of course, the applicator surface area, similar to what ultrasound is all about. How do you determine the size of your sound head? It's based on the surface of treatment that you're going to have to do to deal with. And here's the same thing. If it's a small lesion, you use a smaller head. If it's a larger one, you use a larger one. Applicator displacement. It can be static or dynamic. It would make sense with focused shockwave to use static only because you want to get there like the surgeon does when you do lithotripsy, okay? And analgesia, not required. Now let's talk about the case, okay? Let's see, let me try to put for you what I just said, which was an overview, and put it into a case that you may have. Right now, if I was to ask you, how many patients do you have right now that have chronic lateral epicondylalgia, and that they have been with you for a few weeks, a few days, or they come from previous treatments and their history is really big? First of all, when we deal with chronic elbow tendinopathy, one thing is clear. We're not dealing with a tendinitis, okay? We're dealing with a tendinosis. What's the difference? You know, a tendinitis is that you have all the reason to believe that there is an inflammation there. So that will require a special treatment. But the evidence show that somebody that has a tennis elbow and it's been dragging for 3 months, 4 months, there's no inflammation there. How do we know that? Well, you took a biopsy and you look under the scope. And what they found is that at the insertion, the tendon part of the ECRB, the extensor carpi radialis brevis, one of the most powerful wrist extensor that you have, it is there that the problem is. And what do they find? They find some immature repair tissue. And the name given to that is angiofibroblastic hyperplasia. That is, there was an effort by the tissue to heal because you get chronic tennis elbow usually by overuse. It's micro tear that adds up over the weeks, over the months, and create that problem. And then if you look at it under the microscope, this is the kind of an immature tissue. And the process is stalled. Remember the slide previous, inflammation and proliferation? The mechanism of healing is stalled. That's why something is gonna have to happen to this patient. Otherwise, you could drag that thing for still more months. So what I've done here is to list the therapeutics that is available to you. And you're familiar with all of them. Briefly, I ranked them from level 1 to level 4. Level 1, of course, what do? We use rest. Of course, we use a brace. We may use over-the-counter medication. We will use ultrasound. We will use transverse friction. We will use progressive strength training, stretching. It doesn't work. What do? You, or I know as physical therapists, we will say, okay, well, let's have a look at medicine. What can they do? So you refer that to somebody you know. Physicians medicine look at this. You're a general practitioner usually. They say, okay, we'll try an injection. I will inject you with 4 different things. What's the basis behind those injections? Quickly, corticosteroids, you know, it's to kill inflammation. Why? There's none. So the evidence is not too good in using this today. Now, what about botulinum toxin? This, when injected in the ECB, will paralyze it for a few weeks, for a few months. Therefore, relaxing it, therefore allowing this muscle tendon to heal. Makes sense, doesn't it? and it's used. It doesn't work. They may use prolotherapy. What's prolotherapy? It's injecting an irritant substance in the muscle and tendon. It is to cause an injury. Remember, needling is causing an injury. You will make the area bleed, and that's a good idea. That's a good idea. They try to trigger that healing process, but it doesn't work. So what do we do now? We go for platelet-rich plasma injection. What is that? Take the blood from the patient, go to the lab, process it, come back with a plasma that is very, very rich in platelets. And then you re-inject this into the sighted region. This contains a ton of growth factor. And the rationale here, the scientific rationale, is that this is going to trigger the healing process. But it doesn't work. As of 15 years ago, what was the next step? There was no third level. Surgery. Go for surgery. This is the purpose of my presentation today. I hope at the end, and you will see a little bit later, that I'm convincing you that it is worth trying extracorporeal shockwave therapy for everything I told you about and the scientific basis I gave you. Because if you skip that and you go for surgery, what's there for you? Open surgery? You'll see that shortly. Arthroscopic surgery? Yeah, it's less invasive. It's faster, less demanding for the patient, but still a surgery with all the surgical risk and the long recuperation that comes with it. Recently, as of about 10 years ago, surgeons use histotripsy. The word tripsy, yeah. What is that? It's called a FAST technique. It stands for focal aspiration of soft tissue. What is that? Briefly, they use an ultrasound. Here we go. But this time, friends, it's high frequency, similar to a MEG, but the amplitude of this frequency is, we're talking here of way, way large shockwave energy, very, very large, that will pulverize the angiofibroblastic hyperplasia tissue. You don't remove it with a scalpel anymore. You just pulverize it with an ultrasound device. And then this device is coupled with a mechanism to aspire the material. So it's aspiration after. So you just introduce the needle, you withdraw the needle, you put a little Band-Aid, takes about 20 minutes. Still surgery, but much better than the two previous ones. Now we'll present two short videos. I'll give you a choice. Do you want this open surgery treatment for your chronic tendinopathy, or do you want the next one, which is application of shockwave therapy? Let's have a look at those.
This is Bobby Chowder, and this is our approach for open treatment of lateral condylitis here at University of Virginia. So I use a oblique incision just the anterior to the lateral epicondyle. Careful dissection is performed down to the level of the fascia. Usually there's no significant cutaneous nerves at this region. Hemostasis should be obtained, and careful dissection performed, exposing the underlying fascia and exposing the interval between the ECRL and EDC tendons. I tend to keep the forearm pronated during this approach to make sure that there's no traction injury to the posterior anterior nerve. The interval between ECRL and EDC is carefully created and dissection performed to expose the ECRB origin as shown here. The pathology is at the level, frequently at the level of the ECRB origin, and the goal for this procedure is to resect any of the abnormal tendon, as shown here. This is done meticulously so that all abnormal tendon is resected. This should also be done carefully as the radiocarpal joint is just below you, and you should not violate the underlying cartilage. The lateral epicondyle should be exposed. The anterior portion should be exposed to prevent iatrogenic injury to the lateral thoracic ligament. The epicondyle is exposed and a partial epicondylectomy is performed. I then drill the epicondyle to enhance healing with a point of 4 or 5 K wire. Once this is completed, the interval between the ECRL and EDC is closed, incorporating the underlying ECRB tissue, so a side-to-side repair is obtained of the ECRB tendon. An exam can be performed of the collateral ligament to ensure there's no posterior lateral rotatory instability. A watertight closure is obtained to make sure you do not have problems with a synovial fistula that can develop if there's not a watertight closure. Hemostasis is obtained after dropping the tourniquet and the skin is closed using an absorbable suture. I place the patient, after appropriate dressing is placed, I place the patient in a posterior splint until their first post-op visit of 2 weeks, at which point various therapy regimens are initiated.
Okay, here you go. Now, do you want that or the next one? Keep in mind, you have clinical background. You know that this is, first of all, let's make everything goes well. You don't have any post-surgical complication. Second, in a brace, it's 3 months, it's 4 months, it could be 5 months. But the success rate with this, because we tend to think that because it's surgery, it works. Well, I don't know if you read the literature like I do, but no, it's not because it's medical or surgical that it works. They have the failure. And here, this success for this is roughly between 70 and 85%. There will be a 15% patient that will go through this and we'll be back to square one. Because how do I go to the next? Okay. Because then we didn't have this option. I'm not saying that this option is miracle, because the success rate for this is similar to surgery. That's the good news. It will not heal everything. But look at how easy it is. Radial shockwave. You won't see image guiding. Sometimes they say that silence is worth a lot of words. Compared with equal success rate. By the way, shockwave therapy, radial and focus, has now been approved in the States. It's FDA approved for 2 conditions, tennis elbow and plantar fasciopathy. Okay? Now, the bottom line. The bottom line of this presentation. Well, I'm convinced anyway, I hope I was able to convince you, that this form of therapy is without a doubt promising, it's evidence-based, and it's worthy of recognition by all of us dealing with chronic soft tissue conditions like tendinopathies. Now, I will answer 2 questions here. Which one is best, focused or radial? Where do you should put your money? Well, the evidence shows this. They're both practically equal. The only thing that will change is that if you're dealing with conditions that are very small and deep, then you should favor the focused. More expensive, but get a better result. But practically speaking, for most, you'll see that. Answer to the second question. You might have seen my flyer via Dr. Valdez. What are we talking about here? Are we talking about something that is sham therapy or perhaps a breakthrough? Well, I think based on what we know today, and God knows what's going to happen in the next 10 years, is that we are closer to a breakthrough. Will it be nice if we can get rid of surgery? Orthopedic surgeon will not be happy. We know that. But we will be extremely happy. Not because of us, but the patient. Let's not forget what the patient goes through. All right? So, in my view, closer to a breakthrough with this particular treatment. In closing now, let me thank sincerely all the sponsors, the Montreal University alumni, MedWest, of course, and the Alberta Athletic Therapists Association. I was received like a king, and I really enjoyed being here with you. And of course, special thanks to this man here, Dr. Valdez, that we exchanged a few emails over the past few months, but look at this, everything's worked perfectly, so thank you so much. And now, I thank you, but you know what? I welcome your questions, but I have a deal. If your questions are too difficult, then my two distinguished guests here will answer them. They both said yes, because we discussed that last night. So thank you very much.
Yeah. We'll have Mark facilitate one question just for time's sake, and again, we'll have an opportunity for Q&A at the end. So I'll just hand it over to Mark.
Just because we have an online question, I thought we'd address that. The person in Savannah would like to know if there are any contraindications to shockwave therapy.
Yeah, I would say the major one is people that have blood disorders, coagulation, those that are on blood thinner. That is perhaps the most, and of course, never over an area that was exposed to radiotherapy like a tumor, and not over an acute area, of course, because you will amplify the situation. So roughly, this is pretty much what. But the most important, the most important one is blood issue, because you will bleed.
Thank you.
Thank you so much. Thank you again, Alan, for a great presentation.